Hello, everybody. All right. That is the official cue to cease all conversation. All right. So welcome, those of you here in the auditorium and on Zoom. Today is our annual Nasrallah lecture. And we have an excellent speaker. And I'm glad you're all here. I want to say a few words before I introduce our speaker. So the Nasrallah lecture, of course, is due to or made possible by a gift from Henry and Amelia Nasrallah. And some of you may know Henry. He's a distinguished psychiatrist and psychopathology researcher who's made many important contributions to psychiatry, is editing several journals, and who did his psychiatry residency here in the Department of Psychiatry at the U of R. So that's his connection here. He's currently vice chair for faculty development and mentorship, professor of psychiatry, neurology, and neuroscience, medical director of the neuropsychiatry program, and the director of the schizophrenia program in the Department of Psychiatry and Behavioral Neuroscience at the University of Cincinnati College of Medicine. Now, for our lecture today, like all grand rounds, for the people on Zoom, just want to mention a few things. So if you're watching on Zoom, your camera and microphone will be off and will remain off throughout the presentation. Please do not use the chat function to send messages. That's really reserved for the panelists and the interpreters. But we hope you have comments or questions. And if you do, please put those in the Q&A box, and I'll read those off at the end, get through as many as we can. And last thing I want to mention is to please complete the evaluation at the end. There'll be a QR code that comes up on the screen and a slide with a link in the chat. And tomorrow an email should go out with another link to the evaluation if you can't get to it today. Okay, so now it's really my great pleasure to introduce today's speaker, who is Dr. Dolores Malaspina, who is a professor of psychiatry, neuroscience, and genetics and genomics with tenure, and the director of the system-wide psychosis program, and the first vice chair of diversity, equity, and inclusion system-wide in psychiatry at the Icahn School of Medicine, which is part of Mount Sinai's system in New York City. Let me say a few words by the way of background. Dr. Malaspina received her bachelor's degree in environmental biology from Boston University, and then got a master's of science in zoology, something not a lot of psychiatrists have, from Rutgers, and MPH, specializing in epidemiology from Columbia University, then received her MD from Rutgers, and completed a residency and a research fellowship, a postdoctoral fellowship at Columbia. During her career, she's been a faculty member at Columbia, NYU, Medical Center, and now at Mount Sinai. And I invited her to give the Nasrallah lecture because I think she's doing some of the most interesting research in schizophrenia and in psychiatry, and has been able to integrate, not only study interesting things, but integrate them in a really creative way. She's been doing this for many years, has won many awards. And really, you know, here in Rochester, we talk a lot about the biopsychosocial model. So if you want to see a good example of that, then pay attention today, because I think this is really creative example of what that can look like. Really, as you know, schizophrenia patient outcomes for the most part have not improved in many years. It's arguable that we've really made any advances at all, despite all the work in genetics and brain imaging. And so really creative synthesis and new approaches are needed. And I think that Dr. Malaspina's work really embodies that. So without any further delay, let me get out of here and let's welcome Dr. Malaspina.
Thanks so much, Steve, and thank all of you for attending. I have some disclaimers, which is that I have no conflicts of interest of any kind. I serve on the DSM, steering committee now, previously the psychosis chapters, and that's not something that we do in terms of conflicts of interest. So my title is The Sociobiology of Schizophrenia. You know, I think as Steve said, we've done so much work. Where are we worldwide? Well, worldwide, the prevalence of schizophrenia is increasing and has done so quite substantially over the last 30 years. The incidence is increasing. It's not just that people are living longer, and the actual disability of people with the disorder is increasing. This is startling and greatly concerning. I want to take you back over 100 years ago to a time when NIMH funded psychiatric anthropologists. And they did so because it had become clear that schizophrenia was concentrated in the cities, and that returning from wars, there was a great increase in the risk for schizophrenia. And there was a real desire to understand what might cause that social effect. Now, let's fast forward as we revisit this to another map of Chicago, this one from the COVID epidemic. And what you see is there are pockets of enormously increased risk and increased death, right? And that's what was seen for schizophrenia in the past. That gave rise to the idea that there could be social causation. That idea was really upended by the 1980s, certainly while Ronald Reagan was president. And NIMH underwent a very large change away from ideas of social causation and to a focus on individual genes and individual brains to understand this illness. Some proponents of social causes spoke of weathering. There were many brilliant hypotheses. During my residency, I worked with Bruce Dornwind, who was an amazing psychiatric anthropologist. Well, also after COVID, what we focus on is what the World Health Organization and the Center for Disease Control consider to me the most important causes of diseases. And that includes psychiatric diseases. These are the social determinants of mental health. Now, many of them we'd studied along the way with schizophrenia: poor access to health care, food insecurity, low education, impoverished background, social exclusion. These all are the risk factors for all chronic conditions. And they mimic what the CDC has identified. So we really need to take another look at understanding the causes of our severe chronic conditions, right? And those are those of severe mental illness. So I entered psychiatric training and research with a perspective that's unusual. My background was environmental biology and evolution, how organisms impacted the environment and vice versa, and as a zoologist. And my understanding was what explains the behavior of a social species. And I'll explain to you shortly why I focused at one point on gene mutations. I mean, that could affect a species. But also there's variants of genes maintained in the population to allow you to adapt to different environments. And now we know there's also epigenetics, so we don't separate out nature and nurture. But we know, in fact, that pivotal life exposures are operating by changing gene expression. And that is done by these epigenetic mechanisms. Now, Lamarck first proposed that, with the idea in the cartoon made about his work of the giraffes having increasingly longer necks. And we laughed about that in 7th grade science, but Darwin didn't laugh about it. Darwin fully expected that both forms of adaptation to the environment would be important: epigenetic to short-term environmental changes that impacted an organism, and genetic, which happened very, very slowly. Now we also are pondering, what about intergenerational exposures? What about starvation of men in puberty and the birth weights of their grandchildren? What about exposure to famine and the next generation? So we are thinking of intergenerational exposures as well. Now, I didn't end up becoming a psychiatrist at random instead of an environmental lobbyist, which might have been more needed at the time, looking at where we've gone. But I became a psychiatrist to understand the horrible schizophrenia that my sister had developed. And I wanted to go to Columbia because that's where Ralph Wharton wrote a paper about her that appeared in the American Journal of Psychiatry in 1980. Called The Accidental Lithium Carbonate Treatment of Thyrotoxicosis as Mania. And it's my way to let you know that persons with schizophrenia have a great excess of autoimmune disorders. And these run in the families of persons with schizophrenia. And if you start with the database of inflammatory conditions, a registry, you will find the relatives have a greatly increased risk for schizophrenia. Now, we had to go to a lot of family meetings, of course, when my sister developed this illness, when we were told that my mom actually did that my mother was schizophrenic and that she had caused this terrible disease. I don't think she ever recovered from that pronouncement. And I thought, this is ridiculous. What kind of a field believes this and says this? And so I became someone who went to medical school, went to psychiatry, and read that, in fact, the other idea was that it's a genetic disease. It just runs in families. I had 32 first cousins, none of them with severe mental disease, quite a large family. And my thought before residency, well, if this is genetic, it must be new mutations. And that was a perspective. Now, we know schizophrenia is highly familial, and you've all seen this chart showing the increased recurrence risks based on degrees of genetic relatedness to a proband. But did you know that 80% of people with schizophrenia have no family history at all? Right? Schizophrenia is by and large a sporadic disease, right? And it's important to keep that in mind because the perspectives can shift, like the pendulum swung from social causation to a gene. So my interest was, how could you explain that? Well, it turns out in humans, as in other mammals, mutations are related to the age of the father at the birth of the child. 80% or 90% of de novo mutations into the human population have this origin. This is very, very well known in all of medicine, but I believe this must be true of schizophrenia if it's related to new mutations. It was for that reason, after my residency, actually, I got a degree in epidemiology so that I could find a cohort and I could check this out. Now, spermatogonia accumulate errors. They begin dividing off hub cells when a man reaches puberty, and they divide and divide and divide. And with each division is an opportunity for a copy error or a mutation of one type or another. Every original idea is not original. I found this information on Paracelsus, who really introduced modern medicine to the world in the late 1400s. And he proposed that insanity was due to sperm that somehow lacked a power to build the brain. You know, at that point, they drew a little homunculus inside the sperm. But here's the idea of this insanity originating in the male germ line. If you look at this purple dot that I've drawn, you see that after the first purple dot, it expands over time. And that's because the mutations that are related to schizophrenia and autism have a shorter cell cycle. So they are dividing and dividing more quickly than other cells. Now, it's not just in spermatogonia. This happens in all tissues. And it's really the cutting edge of science to understand that some of the cells within tissues are adapting to specific environments. So we know that some cell division in tissues can lead to a cancer, but there's other types of selection for clones of cells. There's a thought that maybe some brain diseases are from newly arising types of cell mutation. In schizophrenia, as I said, the idea that maybe a de novo mutation happens was another thought of a scientist named Book in the 1950s. And that was based on the fact that in large Scandinavian pedigrees, it seemed that there was a first case of schizophrenia where none existed before, and then a rather Mendelian segregation of that, right? So this would be the idea that mutations can enter the population as a sporadic case, a rare gene variant, but then travel a few generations. We have worked and understood that mutations do occur in sperm, many of them, most of them, probably neutral. Some are so virulent, they cause a spermatogonial testicular cancer, but others are adding to the gene pool these variations of genes with shorter half-lives, often acting in important pathways as stop codons or promoters of gene expression. Now, how do you test an idea like that? I looked in the schizophrenia research unit that I'd opened, segregated my cases into familial and sporadic, got all their family history data, but you really need a birth cohort. You need to prove causation, a population in which no one has the disease of interest or the exposure of interest prior to the establishment of that cohort. And my good fortune was to begin work in the Jerusalem perinatal cohort study. This was everyone born from 64 to 76 in Jerusalem. I trained many of my K awardees using data from this cohort and continue now to work with this amazing group of individuals, but did have 13 years of NIH funding for the study. And what we found right off the bat was when you controlled mother's age for fathers and father's age for mothers, you got this relative risk related to paternal age. I think there are 22 subsequent studies, all have the exact finding that this one does. There's no failure to show that increasing paternal age is related to schizophrenia. But likewise, if you were looking at any sporadic disease, like Huntington's or certainly achondroplasia, sporadic diseases show slightly older fathers. And that's been very clear for a long time in statements by the American College of Medical Genetics. And we don't usually ask the father's age because these can occur randomly in the population. But what most of my colleagues said, who are men, was, well, that's ridiculous. Now, mind you, they hadn't said that's ridiculous when schizophrenogenic mothers were proposed, but they did offer that opinion when dads were implicated. And they said instead, no, it's that men who are already odd and have issues are just marrying later. That's why we're seeing this. But, you know, that turns out not to explain it at all, although I still am asked to review papers stating that, because in my original birth cohort, I controlled for several things that could be related to the risk for schizophrenia and found paternal age was quite separate. One, does mom or dad have schizophrenia? Or perhaps another serious mental illness. In fact, that was related to a 4 to 6-fold increase in the offspring. Paternal age had a robust effect. But here is the one that the other studies neglected to do, and that's a short duration of sexual cohabitation by parents at the time of the pregnancy. That's called a short duration of marriage. And in this study in Israel, the entire cohort was married. They married young, which was a pressure to do so. and we knew the date of the marriage from the registry. And in fact, a very short duration of marriage predicted a higher rate of schizophrenia. You might think of it as related to the possibility that mother's immune system is becoming habituated to paternal proteins during sexual encounters, right? And when the father varies from the mother significantly, there can be a resistance, an endothelial disruption as the trophoplast implants into the uterus. My old professors in medical school had always said there's an increase in schizophrenia in the very firstborn and the very lastborn. If that holds up, it suggests the risk to the firstborn is very inflammatory, a pro-inflammatory exposure. These moms get more preeclampsia, more hypertensive diseases of pregnancy. And it's very well known, and a major risk factor for that is a short duration of sexual contact. So this shows that no, paternal age itself is the risk factor. And I pass no judgment on my many male colleagues who married and had children later. And I'll also say that being wanted is a bit of a protective factor. So I don't discourage parenting at any age, but I think it's important nonetheless to know the data. I'm a clinician. I have a number of my female patients getting their eggs frozen. But I want to, mention that I used to have a title of my talk called Sperm Banks and Boxer Shorts, because there are ways to think about male reproductive health as well. But here's a very large data set that I've collected over time. And this is just a data set, but looking using machine learning at what's accounting and influencing diagnoses of schizophrenia. What we found, and you look just to the one classifying schizophrenia, and what we found among people is that a low GAF score, low ability to function, and paternal age later had the greatest power of predicting schizophrenia from among other cases. Also, there are new studies more and more showing the paternal age effect. Here's one in 3 million Danes by John McGrath, who's really about the most talented psychiatric epidemiologist, possibly worldwide or probably, and they looked at all of the births. And what they found that schizophrenia per decade increased by 1.54 relative risk per decade of a man, starting with 25. So this is a continuing increase. They also found that younger mothers had an increase. But here's a newer paper, which is just 7 million Taiwanese. So the whole population cross-linked to the psychiatric case registries and the demographic information showed that possibly 58% of schizophrenia could be explained by the combination of father's age and grandfather's ages, right? So that these factors together were playing a very important role. They found the same for autism. We find it for bipolar, but only psychotic bipolar, and for suicide as well. A very large increase in this risk based on paternal age. So paternal age is increasing worldwide. Might that account for the increasing risk of schizophrenia is one question. And if you've looked at that Manhattan plot on the bottom, from the psychiatry genomics cohort, and I have been a contributor to this for more than a decade, ascertaining, recruiting, assessing, and diagnosing cases, you see that the common genes, which we plot here by chromosome, having a very small contribution to the population attributable risk. So the genetics of schizophrenia is by and large rare gene variants and not the common ones. But the most important common genes on chromosome 6 are your human histocompatibility loci. So these are genes controlling your inflammatory responsivity. right? So, gee, maybe the biopsychosocial model started in Rochester, but so did psychoneuroimmunology, right? So did the idea that the brain and the immune system are in constant communication and that there could be a clue here to better understand schizophrenia. Now, as a quick aside, within the Jerusalem cohort, we went back and we recruited sporadic cases from the hospital and their willing parents, did exome sequencing of mom and dad and the sporadic offspring, and found a handful of de novo gene mutations that knocked out the function in a group of genes. For 4 of those genes, in a second study back at Bellevue, an inner city hospital, we found 4 more cases that had different rare variants in those same genes. And interestingly, the cases all had schizophrenia, but they varied a lot in phenotype. So I'm just showing you, for example, that if you look at the verbal in full scale, you'll see there's a green bar and a yellow bar, and they're both doing pretty badly. The green bar is a zinc transporter, and the other one is a gene called ARM, frequently associated with dementia. And the one that had that yellow bar gene actually had gone through college, these 4. They had really good attainment, but then perhaps a degeneration, whereas those in the green bar with a zinc transporter didn't even get through high school, right? So patients can look similar when we get to them, but have had very different developmental histories. And part of that might pertain to genetics. I mean, in the paper which we published, looking at these different families of influential genes, they differed in a lot of other variables as well. And overall, particularly, the zinc transporter had the very highest amount of negative symptoms. The one PTPRG, which is a phosphatase of tyrosine receptor kinase, had much, much more severe psychotic symptoms. So all under the umbrella of schizophrenia, but suggesting we may have ways to identify what are the influential variants, because those may pertain to the optimal treatment. And our way of finding the influential variants was to start with the whole birth cohort, where we knew each parent and offspring's psychiatric history, and then look for sporadic disease and the genetic changes. That's one way to do a rare gene variant clinic. And I think there are half a dozen of them now that are being established to try to identify some of these rare genes that might be particularly influential. And remember, the defect may differ in that gene one person to the next, but knocking that out might be an important avenue. But I want to tell you, most human variation is not genetic. And that's really important to keep in mind, and seems to be something we've forgotten since the time I showed you that map of Chicago. That was shown in 6 other cities as well, that there were areas of the city with a very high incidence of schizophrenia. In my own cohort in Jerusalem, we showed that parental education, the residents, occupational status of the family were very robust, significant predictors of the risk for schizophrenia. But I've seen that in every study I've ever done. You know, level 1, put in socioeconomic status of childhood, and you've taken out a lot of variation in the risk for schizophrenia. So how do you understand that? Well, as a zoologist in the beginning, my thought was, who is a subordinate in the social hierarchy that humans construct? Because we know in a social species of wolves or any other groups of animals, the ones that are subordinate really have less access to resources. Also, very high early death from metabolic and inflammatory conditions. So here's this association with social hierarchies and behavior and metabolic abnormalities. So myself and Cheryl Corcoran worked with Bruce McEwen, tried several times to get funding to pursue this idea. which was not successful. But also, as a social species, we have to accept that we do make hierarchies. Ideally, a social hierarchy is established by the capacities of individuals, to lead, to be a great musician, to bring their own unique individual talents forward. And that's okay, but the tragedy is when social hierarchies are related to groups. And that is very, very costly because you suppress the contributions and the belonging of a group of individuals just because of their group status. And that is a problem. It's a problem in several places, but particularly in the US. I'll mention slavery is ancient. This is the Mona Lisa by Van Gogh. I'm only showing it because the background is the birthplace of my grandfather, Bobbio, in Italy. But his mother was a slave, a Slavic slave. And most slaves in Europe at that time were Slavs. But the issue that Portugal decided in the 1400s is it was too easy for them to get away. And so when Portugal started taking over other countries and colonizing, they decided Black people would be better, as slaves could be harder for them. And so slavery became associated with race through that in this country. And the idea that persons of African descent were genetically inferior, a terrible tragedy in our own Constitution, that a Black person would be 3/5 of a person, really a marker there that we're still struggling to escape from. And also this idea of eugenics. You hear eugenics, you think of Nazis. Eugenics was American. It was an American pseudoscience that was elaborated to justify having some people as slaves. Hitler, of course, used it to decide Jews were inferior, gypsies were inferior. But that science saying some people are inferior was never true. And now, sadly, America needs to correct this and also to stop exporting racism around the world. Psychiatry itself has a very intriguing history of racism, not the point of this talk, but there was someone, Samuel Cartwright, in 1850s, who wanted to have a psychiatric diagnosis for slaves who ran away. And he was going to call that drapetomania. It's not that different from what the police use now, excited delirium, to be overly aggressive. We have come full circle. I did have the opportunity for the DSM-5 TR to show the steering committee a slide presentation I'd prepared on this topic, and then go through the entire DSM and take out references to race and minoritized status. And I do hope the DSM is in a somewhat better status now. It needs to make more progress. Let me tell you, though, we have an increase of schizophrenia among Black persons in the US, but it's related to minoritized status. That was shown a very long time ago. 1932, a robust study found that the Norwegian immigrants who first went to the Midwest and their children were twice as likely to have a diagnosis of schizophrenia. By language and culture, they were minoritized. And then you're thinking again about social stress and status and what is the physiology whereby that can happen. Hope all of you are familiar with the ACE scale. If you're a clinician, it'll take you less than a minute to get an ACE score on your patients. It's adverse childhood experiences or exposures, 10 quick items, rating childhood abuse, household challenges, and neglect. And the CDC did a study with Kaiser Permanente, and what they found was that your score out of those 10 items predicted many, many things. And it did it in a dose-dependent fashion, which is an index of causality. and not just association. Current cigarette smoking, your score on the ACE, IV drug abuse, alcoholism, also auditory hallucinations independent of diagnosis, right? Don't just diagnose somebody having schizophrenia if they have auditory hallucinations, if they otherwise are actually having major depression, and then fail to treat the major depression, right? Very, very important to know about the role of early life adversity in hallucinosis, but also cardiovascular death. So quite independent of habits and behaviors is the prediction that scores of 4 or more of those ACEs predict the metabolic syndrome and earlier mortality. So the burden or the changes we have made to adapt to that early trauma are having a lifelong influence on our health. Now, evolution didn't mean to be unkind, right? So we have to think these things that we see in humans and mice and sheep across species are there for a reason. So evolution's goal is to keep you alive, at least through childbearing, right? And to protect you in some way. And so you can think of some of those effects as possibly protective. I think you see it best if you look at an understanding of prenatal adversity, right? So what we know is that for prenatal stress or prenatal adversity, we can have preterm birth, but we can also have other pretty prominent risk factors. And I studied this in the birth cohort that I described to you in Jerusalem. And what we were able to do is identify the 6-day war, a blessedly short war with very few deaths on either side, but terrifying. And we looked and we saw the impact of this war exposure on the health and outcomes of individuals and on their developmental growth. So a baby is not developing from a blueprint that mom and dad give and it's just coming together. The baby is constantly receiving signals from the maternal milieu about stress and danger and diet and food availability. And what we see was a red bar there is showing you the impact of a second gestational month exposure on the risk for schizophrenia. And it was a female-specific effect, and we had as robust effect for affective disorders for the 3rd month. So we have these critical periods of gestational risk. But what about these offspring in general? So what we see is they are prone to very elevated glucose and insulin resistance, prone to abdominal obesity, prone to hypertension and coagulopathy. Now, over evolution, is that random? Probably not. So the brain and the developing fetus require glucose. So having insulin resistance and a slightly higher glucose can be protective. Likewise, storing fat in the abdomen, or if somebody's gonna kind of hit you with an axe, coagulating your blood. So these formations of chronic diseases are the result of fetal programming. So a fetus is programmed in the womb with certain things that we consider risks, but that could protect an organism in a very adverse environment. And again, you see this across all mammals, all rodents, that adversity at different gestational ages introduces these risks. And we see in our study, it was also related to the risk for schizophrenia and affective disorder. And I would say this would be what we consider fetal programming. It astonishes me, as I teach in a number of med schools, that it's not taught anymore. I hopefully in this medical school, fetal programming is taught, since it is the basis for so many of the chronic conditions. This is a chart showing you the peak in red for when we saw affective psychotic diagnosis, and then the peak in blue. And this is month-to-month exposure to a time when people believed they were about to be annihilated. So what's happening? So an evolved pathway during fetal development is looking for signals that it's an adverse time to be born. The preterm birth is because it might be pretty dangerous for that 9-month pregnant mother to get around if there's predators. Should anything happen, the infant would be likewise compromised. But we see that you can predict preterm birth often in the second gestational month by elevations in maternal glucocorticoids. And those will play a role in these later risks. And the accommodations or the outcome of those risks are diabetes, hypertension, hyperlipidemia, stress sensitivity, psychiatric disorders, all being increased. But I would like you to see the physiological adaptations were meant to help us survive. I mean, another piece here, I've shown you the female specific effects. I mean, it's also important to know that during times of adversity, male fetuses are much more likely to be spontaneously aborted than female fetuses. Some people will say that's male vulnerability. I wonder if it's evolution's plan that if we're going to lose a lot of people, maybe we should hold on to the wombs. I don't mean to anthropomorphize it in that way, but these things are seen across species. Now, there's another complexity that I want to introduce to you that I've been studying, and that is the human microbiome. So I was mentored by Lynn Margulis as an undergraduate. She invented the symbiotic theory of evolution, that idea that microbes and higher organisms are all symbionts. She would have been excited. I wish she'd survived to know that I was actually doing this symbiotic work. So we have within our gut, different ones on our skin, our eyes, our nasal cavity, trillions of different microorganisms. We can't live without these microorganisms. They are true symbionts of the human. They can be reduced by C-section birth, not breastfeeding, maybe some aspect of the host genome. Antibiotic use, particularly when it's unnecessary, should be something you're all concerned about, but also infections of mom or the offspring. The gut microbiome is our anti-inflammatory organ, right? So of course you're all having 5 fruits and vegetables a day and having apple cider vinegar. You want to do everything you can to keep your gut microbiome healthy. In every chronic disease they've looked at, they find an aberrant, we call dysbiosis of the gut microbiome. The gut microbiome is also passed through human populations uniparentally from mother to offspring. And the microbiome is passed at vaginal birth. So it's very, very crucial. And the mother's microbiome, hopefully enriched by lots of fruits and vegetables, plays a role in the maturation and final development of her fetus as well, right? So there's a lot of amazing new knowledge over the last decade concerning our gut microbiome. The gut microbiome that you have at birth controls the final development of the brain postnatally and stamps your immune identity. So it plays a very, very crucial role for the humans. From the gut, we have nerves that go to the brain, right? We have our autonomic nervous system connecting the gut to the brain. And then we also have circulating protective substances made by the bacteria secreted into the bloodstream. So, I mean, it's just really nascent, but it couldn't be more amazing. Ours was the first R01 to look at the gut-brain axis in a person. And my interest was hippocampal inflammation, which I had early on found was characteristic of psychosis. that in the first imaging study I did of med-free patients, the end of my fellowship, we were able to show that med-free patients with psychosis had greatly increased blood flow to the hippocampus and later showed it was inflammation. So our question was, could the microbiome play a role in systemic inflammation, but also hippocampal inflammation, and thereby be a modifiable risk pathway to schizophrenia? I mean, the gut-brain axis is amazing. I'll go quickly because I don't want to show you all the billions of slides about it. I have some, but they're only for illustration. But I do want to say that the mass extinction is not just the polar bears, that we are undergoing in Western societies a mass extinction of the healthy microbiome, right? And as the microbiome diminishes, so does the rate of autoimmune diseases. So the importance of the microbiome to inflammation is without any question right now. So in our study, we have research interviews, life course trauma, the matrix for cognition. We imaged the brain, blood biomarkers. We invented a questionnaire, and we studied people with psychosis, depression with and without psychosis, and healthy controls. Let me tell you simply. So to our surprise, the oral microbiome was highly influencing psychiatric health. You know, until about 15 years ago, every state hospital in New York had a full-time dentist. And in our data, we actually asked how many times a day they brushed their teeth, if at all, and it did not explain the oral microbiome abnormality. And some of the species there, we did just publish this, I can refer people to it, are associated with bad outcomes in other diseases. We looked at trauma, not surprisingly. If you look at trauma, this was with the ETI, the Early Trauma Inventory, which has more depth and breadth than the ACEs, but our depression cases and our psychotic cases had robustly more exposure to trauma than did our healthy subjects, as always seen. So let me tell you about another evolutionary conserved pathway of interest to us all, and that has to do with life course adversity. So there is a conserved transcriptional response to adversity, CTRA, and with high sympathetic sustained activity, and this has been shown particularly for psychiatric diseases later on, what happens is there's an evolved system. This is even seen in small vertebrate fishes, but do not go home and stress your fish tank. When there is trauma, it sends signals, and those signals, very importantly, shift the expression of inflammatory genes, right? So inflammatory gene expression is greatly increased, but also there are changes to the bone marrow so that more monocytes are produced. And this conserved response to trauma is seen across all vertebrates. It's associated with coronary artery disease, with cancer, with viral infection. And I've mentioned this picture here from Stephen Cole. More and more psychiatric diseases as well. Like, why might somebody have a pro-inflammatory physiology? Well, this links the adverse exposures to pathways that evolved to make you more ready to fight off infection. And infection has wiped out so many humans. I was reading recently about when the explorers discovered, South America, the diseases they brought killed off about 56 million people, right? So this, if evolution thinks that you're going to have trouble getting along with people, it really wants you to fight off infection. It's just my way of understanding how we're bridging first in fetal development to different physiology, and now as well with early trauma. Now, let me, in a final minute or two, this is just a picture of the brain. Many, many years ago, I gave my daughter MRIs to take to kindergarten for some science fair, and the school thanked me so much for the pictures of prenatal babies with a sonogram. But you all know this is a brain. And I work with Oded Ganon, and he's an amazing physicist at NYU. He developed a method that takes the entire three-dimensional multivoxel hippocampus, and you can image it and spread out with spectroscopy different peaks that are telling you the integrity of myelin, the integrity of glia, and the different cell components. So that was our biomarker in this study to see what could predict the hippocampal inflammation. Now, this was the first study to comprehensively assess neuropathy, autonomic neuropathy, not just resting, but on challenge tests. And what we found is that we could explain the brain metabolic abnormality based on reflexes of the heart that control blood flow, right? So, when you stand or sit or have an activity, we have finely tuned mechanisms that regulate that blood flow. These were significantly abnormal only in schizophrenia. And one of them in particular, the baroreceptor reflex, can be separated into a vagal component and a sympathetic, component. And what we saw was that they actually were predicting different pathologies we saw among schizophrenia. When the defect was largely in the vagus component, which is the anti-inflammatory component to the body, we saw a loss of important cellular signals. When the abnormality was increased sympathetic fight or flight, we had an inflammatory condition of myelin. And I mention this here because I also worked in the middle of my R01 with a really brilliant ophthalmologist engineer, Toko Chu. And she kind of from the ground up built her own machinery here, and we got our cases to sit through it. And for those of you who look at the retina, what we found was this same abnormality robustly predicted the capillary density at the macula. So the same one that's predicting abnormal brain blood flow and predicting a number of other symptoms was related to a measurable component of the retina that also had to do with blood flow. So here where the vagus is higher, and that's protective, right? You want your heartbeat to be slow if you do long distance running. You'll see, am I doing enough? Because lots of exercise can improve your vagus and lower your heart rate. As you get older, your vagus tends to decline. But when your vagus is low, it's very pro-inflammatory, right? And I think this is really kind of an exciting new window on understanding the importance of the autonomic nervous system. Let me also point out to you, if you do clinical work, there's an interview called the PANS, which is widely used in psychiatric research. Well, there's a 5-factor version of the PANS that lifts out something called activation. And what we found is that was the factor that predicted all the inflammatory disease in our cases. So this is off of the scale we developed, and these are even self-reported, that all of the inflammatory conditions were robustly related to this activation factor. This factor, if you look at the symptoms in it, is like chronic delirium. So it's very intriguing. I have other things to say, but I think I am going to actually stop here and just really talk about the fact how exposures over the life course and even exposures of the father and the mom during pregnancy and before can all influence our physiology and have a role in schizophrenia. I'll stop. do one more slide. There we go. What? Oh, I have to do another scan. Yeah. Please scan the following. Get CME credit and comment.
All right. Well, thank you. That was fascinating. I wish we had more time.
I wish I had less slides. Time is perfect.
Okay. So questions, Brian?
I know that you're a co-author on the 2022 Nature paper with Singh et al. In that paper, the genes that they find that impact the incidence of schizophrenia impacts the glutamatergic system.
Yeah, so a lot of the genes for schizophrenia that we find probably weaken the glutamatergic system, right? So, I mean, does that mean that the glutamatergic abnormality causes the disease? You know, I'm inclined to think not necessarily.
Okay.
They certainly increase the risk for psychosis, perhaps, but I think these other pathways are interesting as well. So, I mean, a lot of the other genes are pro-inflammatory, but if you look at calcium signaling, you know, and if you look at the hub genes like TRIO, certain of the genes that really bring a lot of different pathways together, those are pretty clear as well. So I don't disagree with that.
Yeah.
The question is that the answer? It might be helpful for some new treatments, but I think more of our answer might be in policy.
Okay.
In nutrition, you know, when we get to the big preventive piece. Mm-hmm. But short term, yeah, I think this is very, very important for the treatments.
Okay. Thanks.
A pleasure.
Okay. Well, I have a couple of questions.
Oh, thank you.
I think we may have time for at least one. So talking about nutrition,
yeah.
You know, with the microbiome, it seems like an implication of the data is, of your data, is that diet or maybe supplements, along maybe with yoga and things that will increase vagal activity, could or should be able to improve symptoms and outcomes.
I mean, I do with my, I do. Oh, I can't remember very well. I did. I think I did it. Good. Yeah. So I mean, with my clinical patients, I certainly never advocated for probiotics. My patients are all required to take multivitamin, fish oil, vitamin D. You know, but I think the evidence is accumulating for probiotics. I don't mention any particular one, but diet is very, very important. Staying away from processed food is really, really key. There's new literature that suggests that, you know, as humans speciated in the primate line, we lost a certain protein that cows and other beef and red meat still have, and that there may be an allergic reaction to some extent from certain types of red meat and processed meat. I mean, it's in fitting with the data, but you really need 5 different fruits or vegetables a day to keep your microbiome healthy. I have patients who never eat a fruit or a vegetable. It's pretty astonishing. And among our cohorts, no fruit or vegetable predicted autistic symptoms. So getting people to eat fruit and vegetables again, whole grains, apple cider vinegar, unlimited olive oil. These are all things that are very good. I tell them go by the Mediterranean diet. I mean, the Mediterranean diet, it works in MS. It works in my patients for treatment refractory symptoms. It's pretty powerful. There was a pathologist psychiatrist in the 1930s who ran a unit. He got Pilgrim State, but he was doing the autopsies as well as taking care of people. And he noticed that the guts all looked like they had colitis. And then he was looking at gluten, and he took whole units gluten-free, and the symptoms improved dramatically. So I do move patients gluten-free. My sister is the one who always believed a lot of her severe illness was due to allergies. And I think across so many of her hospitalizations, when she'd start talking about every food allergy in the world, you know, calling them fixed delusions, you know, and I didn't know what to make of that, but I ended up with that forming my interest here in part of this gut-brain axis. Yes, there's a lot of foods we don't tolerate very well. Our guts get leaky. Antibodies to those foods we're not tolerating can get into the circulation. They're very, very pro-inflammatory. I mean, a high school student who did research with me lifted out for my cohort the ones who had gluten intolerance, either self-reported or genetic, and they had the worst performance on this actual reflex, this cardiovagal reflex. So we can't really underestimate, we're back to healthy food. We're back to understanding, what our body needs, which is pretty intriguing. Did that answer your question?
Yes.
Or I might have interrupted before you finished it.
No.
Okay.
Okay, we have no time, but Mike, since it's you.
No need for like antibiotic treatment or probiotics, just.
No, I'm beginning to think there's a need for probiotics. I haven't tested it yet. In our paper that we just published, it's the first half of my study done by Jacqueline Lee, an MD PhD student doing her dissertation on this. We have lifted out several pro-inflammatory species now for different aspects of neuroinflammation. But I'm saying the best thing for your gut microbiome is the fruit and vegetables. The anaerobes that give us the really protective substances in our blood live in the distal colon. They live on the fibers of fruits and vegetables. No juice, no smoothies, really the fruit and vegetable itself. And we need to make sure all children have access to fruit and vegetables. And we need to do everything we can in every state in the country to get adequate, healthy food to children. We're seeing how depriving children of adequate resources has lifelong and reverberating consequences for their health. And I think that that's part of the story.
This is making me think that maybe instead of the chocolate chip cookie and potato chips in the box, they should put a piece of fruit. But that's for another day. Anyway, we're over time. Thank you very much. This was really interesting. Thank you all for coming.